I think the important first thing is it's so nice to be at COMy and a first face-to-face meeting since the pandemic. So for me personally, this is my first overseas trip since then. So it's been absolutely lovely. And I just want to thank Mohammed and Arnon and the organizers for a really outstanding meeting as always. I would say that this probably has been the best meeting because it has that lovely feeling of everyone being back together. And despite the challenges of the pandemic, we've had real progress in the myeloma space during the last two and a half years. So I think in that context, the Belantamab Mafodotin story has been particularly important actually because targeting BCMA we know matters. The question is, how do you do it? In the year of the pandemic, having an outpatient antibody-targeted therapy that you can literally take off the shelf and deliver to a patient, recognizing the challenges with some of the ocular toxicity, but these are manageable and they're outpatient. So this is important. The other thing is that Belantamab Mafodotin does not cause a CRS or cytokine release syndrome, doesn't require hospitalization, and so there are aspects to it that make it attractive especially in the era of the pandemic, as a very useful potential approach. So I think what we sought to do was really show the latest data with Belantamab Mafodotin, especially in combination. I thought Dr. Jadal's discussion around the combination with Pomalidomide was particularly impressive. And in fact, if you look at the PFS, the median PFS in her study, which I think is really quite impressive, her updated data suggests we're north of almost 20 months for a median PFS in a subgroup of patients, which for a relapsed refractory population is quite important. And above all, oral therapy once every 4 to 6 week infusions. I think that's the other takeaway, is that Belantamab being administered either not every 3 weeks, but either every 6 weeks or even every 8 weeks has become a real world approach to using it. So lots of excitement around the combinations. In short, the idea that you can combine it with pomalidomide, you can combine it with Bortezomib, for example. We're also studying it in the context of using gamma secretase inhibitors and so forth. So there are a variety of new approaches going forward. So one of the most important aspects of the conversation at this meeting was the management of the keratopathy and the ocular toxicity. And I think what was very critical was to understand what the ophthalmologists observe using their obviously sophisticated tools of assessment of corneal injury, and at the same time what the patient's reporting. I think reassuringly the corneal injury is reversible. Very importantly, there are simple strategies that may mitigate it, including the appropriate use of lubricants in the eye, and especially artificial tears to moisturize the eye. And I think then also practicalities around the infusion of Belantamab Mafodotin, that the use of an infusion over at least an hour, the use of hydration with the drug, the fact that the interval can be spaced out and you retain efficacy. All of these were, I think, incredibly valuable takeaways for practitioners.